Yeah, hi everyone. Real privilege to be here. Thank you so much for having me. And I come from the lens of the Yagara people in Manjin in Brisbane. So I'm just really quickly going to socialise you to the new aminoglycoside calculators that were perfectly segued from the previous talk. And essentially, there was a need for a dosing calculator identified. In antibiotic version 16, which was the version before the new version dropped on Saturday, we were using actual body weight for patients without obesity and then an adjusted body weight for patients with obesity. And when you've got that sort of a transition from having a different dose descriptor in one group, i.e. obesity, and not in the non-obese population, it's really hard to put into a dosing calculator because there's a cutoff where someone who weighs more gets less once you switch your body size descriptor. What we were able to do with antibiotic 17 is look at the PK/PD data. Prof. Curry first introduced me to the concept that all models are wrong and some models are useful, and it's exactly the same with PK/PD data. It's almost all wrong, but it's certainly useful. So we were able to look at PK/PD data and use lean body weight as our body size descriptor across all dosing weights, and that has really facilitated the use of the introduction of dosing calculators. So this is the reference that really helped us, and there's some Professor Pai there as the first author has really led a lot of the body size descriptor and general PK/PD research. And so essentially using lean body weight as the body size descriptor helped normalise clearance across all patient groups, including underweight and overweight. So once we were able to normalise those pharmacokinetic parameters and see that that was the body size descriptor that equalised things, then we moved towards using that for our dosing. What we also did is increase everyone to 7 milligram per kilogram. So essentially we've gone with 7 milligram per kilogram, lean body weight, across the board. Lean body weight is hard to calculate. TG already wonderfully has a lean body weight calculator, but now they've introduced the lean body weight calculator and the 7 milligram per kilogram dose along with the renal dose reductions for renal impairment into one beautiful calculator. So the first calculator that we saw as the expert group looked like this. And I can't see it, but essentially, we moved on from there. That's what it looked like. It doesn't look like that now. I don't know why I put that in, but anyway, I did. So this is, I went with tobramycin because I wasn't sure what the vibe on gentamicin was anymore. So I've just gone to tobramycin for this talk. So this is the dose calculator. So you get to this on the front TG page where you've got all the guidelines down the side. There's a quick links thing in the middle, and calculators is the fourth or fifth option. Click on that. For the pharmacist, you'll know because you've been going probably to the creatinine clearance calculator for a million years. And now it just follows that down the bottom. There's an amikacin because everything in TG is alphabeticized. So amikacin comes first, gentamicin, then tobramycin. And so you can see here that the dose is calculated using the patient's lean body weight. For patients without sepsis and septic shock, creatinine clearance more than 60, 7 milligram per kilogram lean body weight, 40 to 65 up to 480, less than 40, 4 milligram per kilogram. Query don't use if you don't want to cause any additional toxicity. For patients with sepsis or septic shock, just give 7 milligram per kilogram lean body weight regardless of kidney function, just give a single dose. This is the final product. So here I've put in a patient without sepsis or septic shock who's 180 centimetres, 120 kilos. I mean, put him in the second row for the Brisbane Broncos. But he's 56 kilos, so might have a few injuries. Male, and a serum creatinine of 89, which is not so low that I'm worried about augmented renal clearance. Also, he's not in ICU. And this is telling me to give a dose of 520 milligrams. And then again, I empathise with Dr. Warren, who was talking about people don't read comments, but there's a lot of really useful information. If people look past the dose to the comments, it's really helpful. So because this patient that I've put in actually has quite a high body mass index, it's actually only recommending a single dose. So that's there under dosing frequency. And then the box of how this was derived, I think is just great because if you want to do a different dose because of, whatever reason, I think you can really use this to see how they've come up with this and whether that aligns with what you think are the priorities in this patient. So this says the calculated initial dose without rounding is 530. For practicality, it's been rounded down to the nearest 20 milligrams. The tobramycin dose is based on a lean body weight of 75.8 kilos. And there is this, idea that if you had someone who was an athlete and you were thinking that actually their disposition of adipose tissue was less compared to their increased disposition of muscle, maybe you would feel comfortable going a bit higher. So this is telling you exactly what the lean body weight is, how it's calculated, and because their serum creatinine clearance is 108 mils per minute. I mean, beautiful. All right, so immediately I popped that dose into TDMX to check that it would give me what I wanted. So this is empirical use of the TDMX dosing software that's freely available, developed by Sebastian Winker in Germany. So I've put the exact same patient details in, and you can see that actually to get to an AUC24 MIC of 97.1, which is up the top there, it's saying a dose of 503 milligrams. I mean, shut the front door. You would not believe how relieved I was on Saturday night when that came up. And you can also see the time concentration profile here for aminoglycosides. They've got really low protein binding, less than 10%. We give them fast, we give them as a push, and they just cleared rapidly. So it's much harder. It's a big switch to looking at AUC MIC as the pharmacodynamic parameter of interest for aminoglycosides. It's much easier when you're giving a dose as a bolus to achieve a high peak than a big AUC, because you can see it's just cleared almost immediately. So giving more is actually going to not hugely affect your AUC. Probably if we really are committed to going to an AUC-based approach, we might start giving aminoglycosides over an hour and sort of extending the time that you've got a peak concentration that's high. That's going to drive more of a change in your AUC. I've gone off track here a little bit. But anyway, we give them like this for now. And just to say, you achieve a very high peak concentration here. So the peak concentration here is 22. If you're aiming for 10 times above the MIC and your MIC is 2, you're achieving it. For dosing calculations, we assume an MIC of 1. And so actually you're 22 times above the MIC with the peak, and you're achieving the AUC you need. Sorry, I got a bit confusing there with the administration thing. But anyway. Just did another patient here. This is a female who's 35 and weighs less and gets recommended 320 milligrams. Again, all the information is provided there of how it was come up with. And I, of course, again, popped this into TDMX, which was similar, a touch higher, actually, recommendation 360 as opposed to 320. And she was young. So again, if you were particularly worried and wanted to go a little higher, go for it. But also these are... there's lots of variability. These are empirical doses. So I still was very reassured that it quite closely aligns with what was recommended from the calculator. And then, these are a touch small actually, but the only other thing that I wanted to highlight that you won't be able to see, but the kidney function unknown, you can tick kidney function unknown and it assumes that that their kidney function is not impaired. So if you don't exactly know what their kidney function is, but you're pretty confident that they've got, pre-existing CKD3, you wouldn't necessarily use the kidney function unknown tick. You would probably enter a serum creatinine that would give you the creatinine clearance that you want, unless they had sepsis or septic shock, in which case you can give them 7 milligram per kilogram as a single dose based on lean body weight anyway. Okay, and then just to say, they did some external user testing that apart from like 1 or 2 people who were super negative, the vast majority, there's always a couple of sticklers, the vast majority of people really liked them. So just to say that TG does try really hard to make these things user-friendly, and if you don't think it is user-friendly, please feed it back, because the TG is one of the organisations that really wants you to be happy. Okay, and that's it.
Thanks so much, Amy. Now, does anyone have any questions? Oh, we do. Great. Sorry, Felicia.
Make one comment. Is this on?
Yeah.
If you're having trouble accessing the calculators at the moment, you just need to clear your cache, and they should come up.
Thanks. Actually, Amy, this isn't for you, much as I loved your talk. It's really just a question regarding the spread of ETG. It's becoming so fabulous, but are GPs using it? Do we have any data on what proportion of GPs use it? Because in my experience, not many. And then also, you know, we've got all these private hospitals with a lot of clinicians sole operating in that world. How many urologists and haematologists in the private system, do we have that data? Because so much work is going into this, and yet, you know, we're in a bit of a bubble in the public hospital system.
Yeah, I can't say that we have usage data necessarily down to that sort of level of granularity, but in terms of subscription data, I think the private hospital subscriptions are in the high 90s in terms of 90%. All of the big private hospital groups do have subscriptions to ETG or therapeutic guidelines. I can't believe I said ETG. And then in terms of GP practices, the numbers have actually increased quite a lot recently. So they were quite low compared to public hospitals where you've got about 100%, or you do have 100% access. But I think at last time they're potentially coming up to about 80% now. All GPs who are in training, so all GP registrars, they have access through their training organisations. So that's happened in the last couple of years as well. So definitely seeing an increase in use in general practice.
We're just bringing the microphone down for that.
Sorry, piggybacking off that question, do we have data on whether pages are actually used and accessed? Like, what are the more frequently accessed pages, and are some just collecting dust?
Yeah, we do. This is something that we think about when we do our update. So we try and look at both how often the content is used, but then also thinking about whether it's available in other sources and sort of the, I guess, the urgency of needing sort of the information. So there are definitely topics that we cover in the guidelines that don't get as much use, but they might be infections that there's not a lot of good information in other sources, or it might be that if you see that patient, you need to treat them immediately, and we want to support that. So there is a bit of a combination, but there are definitely some topics, urinary tract infections, community-acquired pneumonia, cellulitis, they're probably the big hitters for us.